Hello and welcome to my YouTube channel. Over the next few weeks, I will be making videos to help NP students study pharmacology in a question and answer format on various topics and comorbidities. Today's video will be on urinary tract infection. Please subscribe to get notification of my videos. Thank you. We're going to begin with the first question. The treatment goals when treating UTI include, answer should be all of the above. Eradication of causative organism is the primary goal of therapy. Relief of symptoms and prevention of recurrent infections are also therapeutic goals. A 17-year-old female with a urinary tract infection. She's healthy, afebrile, and has no drug allergies. Upon assessing her, you find that she has not used antibiotics in the past 6 months. An appropriate first-line antibiotic choice for her would be, answer 2, trimethoprim, sulfamethoxazole. And that's the other name for it is Bactrim, and also you can call it Spectra. Empirical treatment with Spectra or Bactrim, or the other name for it is trimethoprim sulfamethoxazole, is the first-line treatment choice when no complicating factors are present and the rate of local resistance rates is less than 20%. A 3-day treatment is cost-effective, and it also increases compliance and reduces the risk of developing Candida vaginitis. The recommended dose for treating uncomplicated UTIs in adults is 1 double-strength tablet BID for 3 days. The dose of Bactrim to treat UTIs in children older than 2 months of age is 6 to 12 milligram of trimethoprim and 30 to 60 milligram of sulfamethoxazole kilogram per day in 2 divided doses. And with children, you can give them in an oral suspension. The children should be treated with a 10-day regimen. Resistance to Bactrim is seen in patients who have had antibiotic therapy for any reason in the past 3 months, or if they have been hospitalized recently. A 25-year-old female with a urinary tract infection is healthy, afebrile, and has a drug allergy to sulfa. That causes her to have a rash. An appropriate first-line antibiotic choice for her would be, number 4, ciprofloxacin. Fluoroquinolines, including ciprofloxacin, are highly effective in treating UTIs. However, resistance and overuse are hindering its effectiveness to treat other infections. The dose is 250 milligram BID for 3 days, or ciprofloxacin extended release 500 milligram daily for 3 days. Other fluoroquinolines that may be used as a second-line therapy including gatiflaxin 200 milligram to 400 milligram daily, and levofloxacin 250 milligram daily. Moxifloxacin and gemafloxacin are not approved for use with UTIs because they have a very poor concentration in the urine. Fluoroquinolines are not prescribed in children or pregnant women because of concerns for adverse effects on joints and cartilage in animal studies. The The exception is ciprofloxacin, which has FDA approval as second-line therapy in complicated UTI or pyelonephritis in children. In pregnancy, use of ciprofloxacin is only recommended if as a strong clinical indication in the absence of a suitable alternative. Beta-lactam antibiotics such as amoxicillin or the cephalosporin can be prescribed as second-line therapy to patients who are allergic to sulfur or the quinolines, or as a first-line treatment for women who are pregnant. Because 25% to 70% of E. coli is resistant to amoxicillin, it should not be used as a first-line therapy unless patient factors warrant its use. So going back to the question, if the patient was not allergic to sulfur, then we would use these treatments like your Cipro, Bactrim, Orocefin. These antibiotics will generally sterilize the urine and produce symptomatic relief within 24 hours or so. And then Orocefin is given IV, and it can treat pyelonephritis. Okay. Patients who are symptomatic or have severe burning or on urination can have phenazopyridine 200 milligram 3 times a day PO added to their treatment regimen for 2 to 3 days as a urinary analgesic. A 29-year-old pregnant woman at 38 weeks gestation who is diagnosed with a lower urinary tract infection. She is healthy with no drug allergies. Appropriate first-line therapy for her UTI would be? Answer is 3, amoxicillin. Okay. Pregnant patients should be treated with amoxicillin or Augmentin. Now, Augmentin is an oral antibiotic combination consisting of amoxicillin and a beta-lactamase inhibitor called clavulanate potassium. Okay, so it's clavulanate potassium. Amoxicillin actually is a great drug used for UTI, sinusitis, some skin infections, respiratory tract infections, bacterial otitis media. Okay, so it brings me back to this that Augmentin is actually the first line therapy for the prophylactic treatment of dog bite, cat bites, human bites. Okay, so we're going to go back to the rationale for this question. I'm going to repeat myself again. So it's pregnant patients should be treated with amoxicillin or Augmentin, and they should be followed very closely. In pregnancy, amoxicillin is probably a safer alternative since toxicity in pregnancy is unknown, and it is a pregnancy category B drug. Amoxicillin is no longer recommended for empirical therapy in the United States because up to 1/3 of the UTI organisms are resistant. Providers should be aware of local resistance patterns in their community. Providers can consult with their reference laboratory regarding the antibiogram patterns of resistance. The resistant patterns seen in patients may be different from community patterns of resistance. Patients with acute pyelonephritis who are not acutely ill or in whom oral therapy can be assured, that means they're not vomiting, okay, may benefit from 1 to 2 grams of ceftriaxone That is, the other name is Rocephin. It's a third generation cephalosporin. It's given IM at the time of diagnosis and switched to oral therapy on day 2 of treatment. Acutely ill patients require initiating parenteral treatment in an inpatient observation unit or hospital admissions for IV fluids and parenteral antibiotics. Which of the following patients may be treated with a 3-day course of therapy for their urinary tract infection? The answer is a 24-year-old female, and that's number 3. So answer 3, a 24-year-old female. Complicating factors in which short course 3-day therapy is not appropriate for the following: symptoms that are longer than 7 days duration, shaking, chills, flank pain, mid-back that is severe, new occurring with onset of UTI symptoms, history of diabetes, pregnancy, immunosuppressed status, renal calculi, renal insufficiency, discharge from hospital or nursing home within the past 2 weeks, 4 or more UTIs in the past year, and then failure of any of the antibiotic therapy that was used to treat UTI within the past 4 months, or residence of extended care facility. For patients with complicating factors, longer treatment protocol are needed, or referral may be appropriate. Urine culture should be used to guide therapy. A 3-year-old female with a febrile UTI is generally healthy and has no drug allergies. Appropriate initial therapy for her UTI would be number 3, ceftriaxone. Ceftriaxone, the other name is Rocephin. It's a 3rd generation cephalosporin. Febrile UTI is treated aggressively in infants and children because fever is often an indication of pyelonephritis. Infants and children with febrile UTI should receive parenteral antibiotics for the first 24 hours or until afebrile. Ceftriaxone 50 to 75 milligram per kilogram divided every 12 to 24 hours given IV or IM is often used in children older than 3 months of age. Other appropriate parenteral antibiotic choices are cefotaxime, thiazidine, ampicillin, or gentamicin. All infants and children with febrile UTI are evaluated daily until afebrile. Complicated febrile UTI in children warrants inpatient treatment with IV antibiotics. Symptoms warranting inpatient treatment include high fever, toxic appearance, persistent vomiting, moderate to severe dehydration, and poor compliance. In addition, any patients younger than 6 months of age who appear toxic should receive initial inpatient treatment for febrile UTI. The goals for treatment of UTI in infants and children are the same as those for adults, with the exception that a search should be made for anatomical abnormalities of the bladder and kidneys. The American Association of Pediatrics changed its guideline for initial febrile UTI in children aged 2 to 24 months, and now recommends a renal ultrasound for the first infection and voiding. Cystourethropy are the second febrile UTI, provided that a renal ultrasound is normal. The American Association of Pediatrics recommends a renal ultrasound within the first 2 days of treatment. The rationale is that risk of renal scarring is low after one febrile UTI, and the recommendation is meant to prevent unnecessary testing. When treating for healthy, non-pregnant adult patients for UTI, you will monitor for symptom resolution in 48 hours. That's number one. Symptom resolution within 48 hours is considered sufficient monitoring of outcomes. If symptom persists, a urine culture is obtained, and any necessary changes in antimicrobial therapy are instituted. For these patients, a follow-up office visit in 10 to 14 days should be scheduled. For patients with recurrent infections, obtaining and documenting one urine culture is worthwhile, although it is generally unnecessary for women with acute UTI. If the culture is negative despite a positive UA, investigation is needed for organisms that do not grow on standard laboratory media, such as those that cause gonorrhea, chlamydia, and renal tuberculosis. One post-treatment UA is useful to rule out persistent infection or hematuria. Routine UA to test for a cure is generally unnecessary in healthy adult women because of all the main antimicrobial used to treat UTIs have 91% and higher cure rates. Follow-up cultures are appropriate in children, pregnant women, and elderly patients. If it is persistent as opposed to recurrent UTI is suspected, a follow-up UA may be helpful in making this diagnosis. Monitoring for a child who has had a urinary tract infection is, number 2, follow up urine culture at completion of therapy. All children aged 5 years and younger need radiological evaluation and appropriate referral to a pediatric urologist. Older children with a simple, uncomplicated UTI require urine culture for diagnosis of the offending organism and a culture after completion of therapy. Failure to produce sterile urine after 14 days of therapy suggests referral to a urologist. Monitoring for a pregnant woman who has had a urinary tract infection is, number 4, follow up urine culture every 2 weeks until delivery. Pregnant patients with a positive urine culture should have a follow-up urine culture every 2 weeks until delivery and at their postpartum evaluation to validate sterile urine. Reinfections require prophylactic antimicrobial therapy. For upper UTIs, an initial telephone assessment of the patient's symptoms and response to therapy is important within 24 hours. A second assessment with an office visit should occur in 2 to 3 days. If symptoms do not resolve or if they worsen, hospitalization may be required. A urine culture should be done 1 to 2 weeks after therapy in pregnant patients, children, patients who remain symptomatic, and those for whom suppression therapy is being considered. Follow-up cultures are optional for all other patients. Along with an antibiotic prescription, lifestyle education for a non-pregnant adult female who has had a UTI includes: number 2, voiding 10 to 15 minutes after intercourse. Practices that may help to prevent UTIs, especially in women, are voiding 10 to 15 minutes after intercourse. Urination washes out the bacteria from the urethra that may have entered the bladder during intercourse. Avoiding spermicide and diaphragms. Use of these products can cause a change in vaginal pH and flora that increases the potential for vaginal colonization with organisms that are likely to produce UTIs. Non-oxynol 9 spermicides are especially associated with increased incidence of bacteriuria. A healthy non-pregnant adult woman who recently had a urinary tract infection. She is asking about drinking cranberry juice to prevent recurrence of UTI. What would you say to her? The answer is number 2. 100% cranberry juice or cranberry juice extract may decrease UTI in some patients. Additional measures that have inconsistent support but would not be harmful and are likely to be helpful include the following. Number 1, ingesting cranberry juice or cranberry extract. Cranberry substrate exert a biostatic effect. Most studies have been done in elderly women, but the same mechanism may prove effective in younger women and in men. There is no evidence for the effectiveness of cranberry in preventing UTIs in children. Maintaining fluid intake of at least 2,000 ml per day of non-caffeinated fluids. Sufficient fluid is necessary to ensure regular voiding throughout the day. Caffeinated fluids have a mild diuretic effect but are less likely to maintain fluid volume balance. Number 3, not resisting the urge to void. Holding urine may stretch the bladder and cause small breaks in the bladder mucosal layers that provide entrance for bacteria. Holding also increases the risk for growth of bacteria in residual urine. Number 4, avoiding douche products that change the vaginal pH and flora. This practice may decrease the likelihood of vaginal canal colonization. Which antibiotic is recommended for prophylaxis of recurrent UTIs? Your answer is D, nitrofurantoin. Nitrofurantoin and Bactrim are recommended for prophylaxis of UTIs. Okay. I see that Bactrim is probably not one of your choices here, but if it was, I would be choosing Bactrim, and the other name is Septra, also called trimethoprim sulfamethoxazole. The drug of choice for adults for prophylaxis or for recurrent infections, more than 3 infections in 1 year. Okay, so they will be given a prophylactic antibiotic. 1 single strength tablet of Bactrim daily at bedtime for a minimum of 6 months, or a self-administered single dose of 2 double strength tablets at symptom onset. For children, the recommended dose of Bactrim is 2 milligram okay, of trimethoprim and 10 milligram of sulfamethoxazole per kilogram as a single dose, bedtime dose. The nitrofurantoin adult dose is 50 milligram to 100 milligram at bedtime, and for children it is about 1 to 2 milligram per kilogram per day in a single dose. And I see that Augmentin is one of your choices, but it's used to treat UTIs. Okay, that's your amoxicillin and your clavulanic acid. So the next one I see here is your levofloxacin. It is used for the treatment of UTI. And moxifloxacin, which is your fluoroquinolone, is not indicated for the treatment of UTI because they have low concentrations in the urine. And then you have ciprofloxacin and levofloxacin are the two fluoroquinolones indicated for UTIs. Okay? Thank you. What first-line UTI bacteria microbial requires only one dose? Your answer should be A, fosfomycin. Fosfomycin is a first-line UTI antibiotic that requires just one dose. As this drug is available as a single dose, this drug would be most suitable for patients who are at risk for non-adherence to drug regimen. Fosfomycin is a pregnancy risk category B drug. Therefore, the drug may be safely administered in pregnant women. However, fosfomycin is not safe for administration in children. Ciprofloxacin is not a first-line UTI antibiotic and requires more than one dose. Nitrofurantoin and trimethoprim sulfamethoxazole are the first-line UTI antibiotics but require more than one dose. Except for pyelonephritis, what should the practitioner be aware of in the treatment of most UTIs? B. Most oral antibiotics can be treated in the home setting. Except for pyelonephritis, most UTIs can be treated with oral therapy at home. Complicated UTIs and pyelonephritis require IV antibiotics in the hospital. IM antibiotics are infrequently used in the treatment of UTIs. A patient with a severe UTI is prescribed amikacin and penicillin. What instructions should the practitioner include to the prescribed order? The answer is A. Give penicillin first before you give amikacin. Penicillin is administered first because it breaks the bacterial cell wall. After this, amikacin is administered. This drug destroys the bacterial cell, thereby enhancing the effect of the antibiotic. Amikacin can be given both IM and IV. Simultaneous administration of amikacin and penicillin is not effective in treating severe UTI infections. So what is amikacin? Amikacin is an aminoglycoside used short-term for serious infections caused by gram-negative bacteria like E. coli and Pseudomonas species. Clinical studies have shown amikacin IV to be effective in bacterial septicemia, in the respiratory tract, bones, joints, central nervous system, including meningitis. Intra-abdominal infections also been used with the amikacin, burns, post-operative infections like vascular surgery. What would you give to a patient with an acute pyelonephritis? A. Trimethoprim sulfamethoxazole. The other name is Bactrim. It's in the sulfonamide family. Bactrim is an antibiotic used for the treatment of urinary tract infection. It prevents the occurrence of trimethoprim-resistant organism. Phenazopyridine is urinary analgesic used to relieve pain associated with UTI. Taken PO about 100 milligram to 200 milligram TID for 2 to 3 days after meals, and these provide great topical analgesia. Fluvoxate is used for the treatment of urinary tract spasm, so it's an anti-spasmodic drug. And another anti-spasmodic drug is also your darifenacin. Darifenacin is a muscarinic receptor antagonist used to treat overactive bladder disorder. So its action is to relax the bladder, smooth muscles, and to inhibit involuntary detrusor muscle contractions. What condition is treated when trimethoprim and sulfamethoxazole is prescribed? Your answer is C, chronic urinary tract infections. Trimethoprim sulfamethoxazole is a combination of trimethoprim and sulfonamide antibiotics and is used to treat chronic urinary tract infections. For the burning and pain relief during urination, you would use phenazopyridine hydrochloride. And for your overactive bladder, you would use tolterodine tartrate, which is used for overactive bladder. It's an antimuscarinic drug. And then for your urinary spasm or incontinence, you would use oxybutynin. Oxybutynin, another name for it is ditropan. It's used for urinary incontinence and urgency. A patient is prescribed Cefotetan for a urinary tract infection. On day 2 of taking Cefotetan, the patient develops abdominal cramps, nausea, vomiting, excessive sweating, itching, with a pounding headache and a decreased blood pressure. You assess the patient and find what? Your answer is D. The patient drank alcohol while taking Cefotetan. Cefotetan is a second-generation cephalosporin antibiotic. Combining alcohol or ethanol and Cefotetan causes a drug-to-drug interaction. If the patient drinks alcoholic beverages within 72 hours of taking Cefotetan, it causes a disulfiram-like reaction. You'll get stomach cramps, nausea, vomiting, excessive sweating, itching, low blood pressure, pounding headaches, and flushing. These are all symptoms of disulfiram-like reaction. Disulfiram-like effect can occur if you drink alcohol and you take flagyl. So what is disulfiram? Disulfiram, the other name is antabuse, is used to treat chronic alcoholism. It causes an unpleasant effect if used even in small amounts of alcohol consumed. It can cause disulfiram-like drug reaction, like I mentioned before, your abdominal cramping, nausea, vomiting, excessive sweating, itching, low blood pressure, pounding headache, severe headache where people are really in pain, and they actually retch. Sometimes they even tear their esophagus from even retching, and then they have flushing all over their body. Okay, And the other choices are not applicable. Methotrexate does not cause any interaction with cefotetan. Methotrexate interacts with penicillin, though, and decreases its renal elimination. As a result, methotrexate levels in the body are increased. Probenecid interacts with cefotetan and increases the cephalosporin levels in the body. Okay, probenecid is a uricosuric agent used for the treatment of gout and gouty arthritis. Interesting facts about probenecid. It was used during the World War II to extend the half-life of penicillin due to limited supplies of penicillins, for the given to the soldiers. It was found when probenecid used in combination with penicillin to prolong their plasma half-life, and it increases serum levels of penicillin. Okay. Importantly, probenecid have a similar effects on many other medications, inhibiting the tubular secretions and increasing serum levels concentration of drugs such as acetaminophen, naproxen, indomethacin, cefazolin, lorazepam, and rifampin. These are one of the few drugs that I mentioned. Patients taking probenecid should be cautious about use of other medications. Thank you very much for watching. This concludes our UTI questions and answers. Please subscribe to my website and look out for some more questions and answers like these, perhaps even in a case study format. Thank you very much and have a great day.